Anyway, so let's get started with the podcast. Enough about Waterloo, who's not our official sponsor, but Chetara Brisbon. Nice to meet you. How are you doing today?
Yeah, it's nice to meet you as well. I'm great. I'm definitely happy that you have me here today. Really excited to be able to talk to you and your audience.
Well, I'm excited to have you, and thank you for flying in. By the way, I'm still kind of taken aback by the fact that people are willing to fly in for this, and not to necessarily be disparage what we're doing here, but it's just I've never been in a position where people are like, yeah, I'll come out and fly to see you and do a podcast. I'm just super grateful. So thank you for doing that. Definitely want to make it worth your time today, and I think we're going to have a lot of fun talking about nice healthcare. But before we do that, let's get to know you, if that's all right. So, born and raised in Colombia, correct?
Okay. Born and raised in Colombia, South Carolina.
Okay. Tell me about growing up in Colombia, because like I said, I was telling you offline, I've only been there once, and it was beautiful from what I remember, but that was 20 years ago. So tell me about Colombia.
It's okay. You're likely to get all 4 seasons in a week. You just never know.
In a week, okay.
Oh yeah, it's hot right now, but there's days where it's kind of cold too. So
you get 4 seasons. How close is it to the coast?
Where I live, it depends on which coast you're wanting to go to. Charleston is about an hour and a half.
Okay.
And then Myrtle Beach is about 3 hours away.
Okay, and I've heard it's just gorgeous up there, lots of trees. I've never actually been to the beach in kind of the upper north. Well, I guess, is it even considered the Northeast, or are you guys just south of what's considered the Northeast? I mean, you are South Carolina, so yeah.
South.
Look at me exposing my ignorance of geography of my own country here. But so let's I want to get to know more about you growing up in Colombia, family, education. We're going to talk all of those things. So whatever you want to share with us, I'd love to hear your backstory.
Yeah. So I guess I'll start off with family. So me and my partner have a total of 3 kids to get all together. I have a 5-year-old daughter.
Okay.
And then he has a 7-year-old son and a 4-year-old son.
Okay.
Surprisingly, they do all get along. They're like best friends.
I would say that's a full house in that age range. Is like I've got a 15-month-old son, a 4-year-old daughter, and I could tell you life is stressful at times, especially at home. But we don't have 3, so I mean, is it just you guys are running around chasing them all day long, or what?
They're very active.
Very active, yeah.
Very active.
Yeah.
And I'm actually surprised that they do get along so well.
Okay.
So
that's always good.
But they have their moments. They have their moments where they're kind of going back and forth. But overall, it's a lot of love from everyone.
That's awesome. And you said, so your 5-year-old daughter is the youngest, right? Or what? Where there's a 4?
So 7, 5, and 4.
7, 5, and 4. Okay.
Yeah, I have to say it in my head too.
And it's an amazing. No, I just like I have trouble sometimes even remembering the 2, right? And then I just think about, like, you mentioned they get along. Well, my daughter was an only child for 3 years, and then this little guy comes along, and she's like, I'm not so sure I like to share the spotlight so much. Do the 3 get along? But I'm sure there's turf wars, and I'm sure people are fighting over toys and things like that.
Oh, yeah.
But overall they kind of keep it together, and yeah, it's fun. Siblings are so much fun.
They are. There's a total of 5 of us. I've got 2 brothers and 2 sisters. So.
Okay. So you grew up in a pretty big family, too.
Pretty big family. And, it was, I don't know about the getting along part. Maybe when we got older, but now it's great. But back then, not so much.
Yeah, I mean, there's a lot of fighting over toys. And, like, my daughter is she's very, like, she's a leader. And she's very adamant about what she does and doesn't like. And so it's like every time she and my wife maybe go do something, and I'm watching Sebastian, our son, she's like, make sure Sebastian doesn't touch my toys. Like, I don't want him touching my toys. I'm like, all right, you got it. Like, yes, ma'am. It's really funny that she takes control of the situation. But it's fun to see. So that's kind of family life, and you grew up as one of 5. Everybody's still around the South Carolina area?
Everybody's still around.
Very cool.
We're all pretty close together.
Well, I've noticed that too. Like you tend to almost get closer with your siblings as you get older, right, and become adults, and you realize you're not fighting over toys and clothes and things like that anymore. Like you can actually have like a real relationship.
They become your best friends.
Yeah, absolutely. Well, that's really cool. And so you grew up in Colombia, and I didn't know this when I was going through your background, but we had a stint in the Army. So I'd love to hear a little bit how that transpired and your experience with that.
Yeah. So right after I graduated high school, I went right into the military, so the Army.
Mhm.
I did that for 4 years. Going into the Army, what my position was is a 68 Romeo, which is very similar to a health inspector on the civilian side.
Okay.
So we would go in and inspect the commissaries, the smaller stores,
Like
gas
on a base or
stations.
something? Yeah, okay.
On the base. And during my time in, I did 2 deployments to Afghanistan.
Okay.
And then I decided I'm going to do my 4 years and I'm going to get out. And wasn't really sure what I wanted to do when I got out, but I ended up going into sales. And throughout my journey of sales, it led me to Nice Healthcare.
Well, and we'll definitely connect the endpoints in between there because you have a lot of other interesting things I think that you do. But I want to ask you about, because I think you touched on this beforehand, how the role in the 68 Romeo, the health inspector, if you will, kind of introduce you to the kind of the food logistics and the food chain, and so you're getting in there and actually ensuring that things are compliant with certain protocols and it's safe and healthy for people to consume. So what was that like seeing down the chain of the logistics of how the food got to the table?
It really makes you look at food a little bit differently. So when you're able to go to those, to the meat market before they actually send that meat out, or to go to like the water plant and watch them fill up these water bottles, and I don't know, it's very different.
Yeah.
I mean, not to say I'm still going to eat my meat.
Yeah. Same here. Yeah.
But
I tend to just bury my head in the sand when it comes to like how it actually got into the package that goes in the at Kroger when I pick it up. But were you doing the same thing when you were deployed in Afghanistan? Was that a similar role or?
So I did it for my first deployment. However, my second deployment, I was selected to be the training NCO.
Okay.
And that part of my job was to make sure that all of the soldiers were trained not only on their job, but also in additional areas like their equal opportunity, their I'm sorry, I'm trying to think of all the things that they had to train on.
Yeah, so like not necessarily military style training, but some sort of the processes and like programs that are available to them and things like that.
Right.
Was that something you had interest in, or that was it kind of like a promotion, or tell me about that?
Yeah, I actually had interest in it. I was selected over all of my peers to do that because before I filled in for their HR specialist when we didn't have one, and I was really good at it. Somehow, I'm really good at paperwork.
Well, I'm not saying the paperwork, but the people, the interpersonal skills is really, really important in HR.
Oh,
sure.
Yeah. Oh, yeah. And making sure, like HR is such an important role because they depend on you to get their promotions, their awards, making sure that they get to their next station. And it's a lot that goes into just HR by itself. But, I learned so much in both of those, actually all 3 of those roles.
Yeah.
In the military.
Well, and so that was what obviously that led you into school. I guess is that when you went to college after that, or was that same simultaneous? Were you?
Yeah, I was in school while I was in the military too. So I ended up getting my bachelor's in business from Waldorf University.
Okay.
Right after I got out of the military and going into sales, I went on to get my master's in business from Anderson University.
Okay.
Took a little break away from school for a little bit because I said, you know what?
Well deserved. I mean, my goodness. Did you have enough on your plate at that time?
Right. I needed a break. And then the next thing I know, Anderson University reached out and said, hey, we're starting this PhD program. And so I looked at it and I wanted to get my PhD, my doctorate. And so I enrolled, and here I am about halfway through the program.
That's incredible. So, is it a virtual school? Is it online, or is it in what is school even like right now? Because it's like,
that's a really good question. So they have a campus in Anderson, South Carolina.
Okay.
Now Most of the class is just everything. You're kind of doing it on your own.
Okay.
It is online, but they do have those sessions where you do have to log in to like a class meeting, so a virtual class meeting, and actually interact with the other students,
like discussion forums and things like. Yeah, even so, I did some graduate school, some graduate school. God, I'm aging myself, but it's like 15 some odd years ago now, and that was very early on in the virtual days where I was like, I had a class that was online, and I'm like, wait a second, you log on and that's how I do my class, and then all you have to do is really engage in some discussions and then write some papers, and it's like, oh, that's interesting. I'm sure it's obviously morphed considerably with Zoom and things like that nowadays. Yeah. So the PhD, and what is your PhD going to be in?
Yeah, so the PhD is in leadership with a concentration in business.
Okay. So leadership in business, and we were talking a little bit. I know it's still we're honing in on what your dissertation may be on, but that's obviously a big part of the PhD. So tell me kind of how you even come up with like, what am I going to focus on, and what am I going to write about, and what do I want to kind of hang my hat on as the thing the problem I hope to solve. So talk to me some about that.
Yeah, that's a really good question, because we all ask ourselves that when we first started. It's like, okay, what do you want to do? And so each class builds on to your dissertation.
Okay.
So you're not doing it all at one.
Okay, it's not just
time.
like one time. Okay, good. That's a little bit.
So yeah, the first class, you're just kind of building up some research questions, like what are the things that you're interested in, and I'm interested in healthcare.
Okay.
And so, my focus, what I want to address is the relationships that community health centers have with their communities.
Okay.
Because there is a disconnect, and there's not a lot of trust between the communities and the community health centers.
Okay.
And it's still underway with how I'm going to go about it. I know it's going to be a qualitative dissertation, so a lot of case studies, observations, interviews.
In your brainstorming, of course, about that, is there an angle you feel like you want to address, though? Because you've identified the problem, right? A disconnect in the community with the community health centers. I'm sure there's obviously a multitude of reasons why that is. Kind of, what are you thinking along the lines of where some of the solutions might live?
Well, more outreach, I would say. More education to the community. I think that we don't see a lot of educational programs towards the communities, and just, I mean, that is still under research. Just trying to figure out how do we build that relationship.
Well, that's what we were talking about ahead of time too. Is like this is such an infinitely complex. We're not. That's an isolated microcosm of the entire health system, which is obviously far more complex, and it's broken. And we all know healthcare, the situation we're in right now, healthcare and then health insurance as it relates to healthcare. So I realize there's no, hey, I'm just going to wave my pen and then now I've solved the problem with my dissertation. But so that's what's brilliant about that is like with the vast ecosystem we're talking about, you find the thing ultimately that you are passionate about. Then you focus on that problem, or you can do your part into helping solve that particular problem. I think we need more people that are personally and passionately motivated about something that they can address. Like I think way back, like my second podcast, Dr. Bricker was on here, and he said, you can't boil the ocean, right? You can't just overnight solve the whole thing, but what if you solved one problem at a time? Or what if you looked at a subset of the big problem and you helped solve that? Then you make an impact on people right there, and that's a tangible thing you can do. So I hope obviously this is a fruitful endeavor for you, and it sounds like it's something that personally that motivates you to figure it out. And then you'll have to let me know when you do hone in on your dissertation and it's done, kind of what angle you ultimately end up finding. So how long do we have until that looks like that's going to be due? Like, is there an expiration date when it has to be written, or what?
So graduation is 2023.
Okay.
So
and that obviously needs to be. You can't graduate if you haven't completed your dissertation. And then is there a review process where somebody reads it and vets it and says yay or nay, or?
Yes. So about the last semester that I had, we had to submit our proposal to the dissertation committee, so the IRB, and then they get back with us and determine whether or not it's okay for us to go through to the next level to start like your actual research process.
Okay. And then once the paper's done, you start the research process. The intent is that this gets put into motion in the real world, correct? It's not just theoretical, or is it?
So it could be both. It could be both.
Okay.
If you've got a really great idea and a solution, it could be used.
Okay.
I mean, everything is going to get published, and it could fall into the right hands.
I know.
And
then they're going to be coming to you and say, hey, like, we read your dissertation and it was amazing and we think you're right and let's do this and we want you to lead the project, right? I mean, that could possibly be,
it could happen.
That's incredible. I hope that it does. And now you're also doing you're an adjunct professor, is that right? What does that mean, like adjunct?
So you're not like a full-on professor.
Okay.
You are, I don't want to say like right underneath, but you kind of are.
Okay.
So because I just have a master's, it's not like a full-time, it's not full-time for me.
Is it kind of like an apprentice might be or something?
Kind of.
To a degree? Okay.
So a lot of your duty is to, you can teach, but you're also doing a lot of the back-end work too.
Okay.
So kind of building the course, grading papers, things like that.
Okay. And what are you teaching? What is the subject?
So I taught business courses. So basically business 101, like intro to business.
And is that fun? Did you just enjoy it? Did you just get asked to do it and say yes? I mean, like.
So what's funny how I came into that was that I had applied for the position a while ago, and next thing I know, like I never heard back from the college, and then the director reached out to me and she said, hey, I see that you have what we're looking for to be able to teach this course, and we would love for you to chat with us about it. And that's how it got started.
And then that's all she wrote, right? Like so how long you been doing that? Was that recent?
That was recent.
But eventually, right, we're not just going to talk about, education, but once you get the PhD, obviously we'll see what the outcome of the dissertation, if something happens there. You touched on, your eventual career path that got into sales. So what type of sales were you doing when you got was it after you got your undergrad or was that your MBA?
So right after I got out of the military, I went straight into sales.
Oh, you did? Okay. So you were going to school simultaneously while into sales. And was it life insurance?
Just working.
Well, you just pile things on top of you. It's like without having 4 things going on at once, it seems like maybe are you one that just always has to be doing something or?
Yeah, I'm one of those people.
Okay.
I am.
It's type A, I think is what we call that, right? Well, that's good. Well, I mean, obviously your history, what you've accomplished so far, and I'm sure we're barely scratching the surface of what you're gonna accomplish. But so it's sales. You're selling life insurance, right? Was that your introduction to the insurance world at the same time?
Actually, yeah, it was. It was. And before I was selling life insurance, I was in finance, so selling personal loans, and then also like furniture.
Okay.
But when I got into life insurance, it's one of the hardest sales that I've had to
I 100% agree.
Offer. So, but I would go to clients' homes and they would always ask if I sold health insurance.
Okay.
Because it was around open enrollment time, and I told them no, I don't. I just life insurance. But I ended up coming across the previous company that I was with. I don't know if I'm able to say it or not.
Oh, of course you are. Yeah. I mean, we never come on here and like disparage companies or whatever, and it's up to you if you want to, talk about it. For sure.
Yeah. I mean, it was a really great experience, but I came across Blue Cross, and I was like, oh wow, I did the interview, and I really connected with the hiring manager, and it turned out great. It was a really great experience.
What was your role then?
So I was a sales rep with Blue Cross as well.
Okay.
So I sold their individual health, their Medicare, as well as the small group insurance.
Okay, and so you seems like every one of those stops you've had kind of the personal sales angle, right? Like the individual life insurance. Obviously you're doing some of the financial, not advising, right? Coaching, I guess, is on the side. and then we're doing individual and Medicare policies as well. Do you like that, or did you like that space of the one-on-one versus kind of the group setting? I know you did. You said you did some small group, but
yeah, I mean, I actually like them both. The
Okay.
one-on-one is more intimate. Like it's,
Mhm.
I can really build a close relationship
Yeah.
with that individual, as opposed to like a group, and you probably only see the group maybe twice,
Yeah.
two, 3 times.
And so in small group was, what, under 50 market, I guess, right? And
Mhm.
so were you calling on brokers at that time that had small groups, or what?
No. So we either the groups will reach out to us
Mhm.
and say, "Hey, we're looking for health insurance." We could also go out and prospect as well. And then sometimes like of course we would call out to those small groups that were interested, that showed interest in what we offered.
That's cool. And so how long were you there? You were there a few years, weren't you?
Mhm.
And then I guess that leads us right into NICE. Are we in your chronological timeline? Was there a stop in between Blue Cross and NICE, or no?
There was not.
There was not. So we're up to date, and that's that was obviously, and I want to spend some time on NICE Healthcare because, of course, the motivation for you down here, who you represent as the Chief Growth Officer, sounds like a really, really neat solution. But tell me how you ended up becoming aware of them.
Yeah. So with NICE, I'm the director of growth, and I came over to them when okay. Let me backtrack.
Yeah.
So with Blue Cross,
Yeah.
I really enjoyed what I did, loved it. I would always get clients that would come back and say, "Hey, I have health insurance, but I just can't afford to actually use it."
Yeah.
And you see that often.
Mhm.
And so I remember coming across NICE Healthcare on LinkedIn, and I looked at the company because I was like, "Who is this NICE Healthcare?" Looked at the company, saw what they did, and I was like, "Wow, this is a great benefit.
Mhm.
It really is something great that would be great, here in South Carolina if it was offered.
If it was offered,
there."
yeah.
Yeah, and I saw that they had a position open, and I really wanted to be a part of the mission
Mhm.
that they had, which is to make healthcare more convenient and affordable.
Yeah.
And that affordable piece is big, especially in states like South Carolina, when we haven't extended Medicaid, and so you have this gap of individuals that can't get Medicaid because
Okay.
they aren't eligible,
Okay.
but then they can't have a health plan either, because they just can't afford it.
Yeah.
Or they have the health plan, and just like I
You
said,
can't afford to use it.
they actually use it. Yeah.
Well, that's what they call that. Functionally uninsured, I think, is the term I've heard used to that. And there's some cool solutions out there that I've heard of for like Patient is the one that come to mind that help the financing side. So the member out of pocket expense, because that sometimes becomes the impediment. It's like, yeah, I've got this health care, but my deductible is $4,000, right? And my
Right.
coinsurance is 30% or whatever. So you're like, yeah, I have it, but I can't even use it, but I pay for it. And that's absolutely like not a position you want people to be in. So you can help with the
Right.
financing, but still that's a symptom of the plan arrangement and the cost. So NICE is taking the approach of, you said, making it more convenient, making it more accessible. So how are you guys doing that?
Yeah. So what NICE is a direct primary care clinic.
Okay.
And we offer virtual and in-home primary care services, along with additional services that's not traditionally offered for primary care, like mental health therapy and physical therapy.
Okay. And so it's virtual, but there's also an element where they're in-home, right? So we're talking about a doctor actually coming out to a person's house for
Right.
a house call, right?
So our clinicians do come out to where the patients are.
Okay.
Mm-hmm.
That's very neat. But that's in certain geographic locations, right? So
right.
Okay.
Right. So right now we are in 12 markets and counting.
Okay.
And that continues to expand today.
Yeah.
It's just rapidly growing.
Well, the model makes sense to me, and like we talked about, I had a conversation where Nice Healthcare came up yesterday in the Minneapolis market, and somebody was singing Nice Healthcare's praises pretty immensely, which is always fun, right? When I was telling you, it's like always fun when you go, all right, well, I think I know a little bit about the solution, but then you hear independently somebody go, wow, this is cool. I've seen it work, and we use it, and I'm like, okay, now I'm excited to talk about it. One question I do have for you that I really want to understand is like, virtual primary care versus telemedicine. Like, what's the difference? Because I know there's a distinction, but I'm not smart enough to know what it is. So what is that?
Yeah. So they often get interlooped together. So people confuse the three. But when you look at telemedicine, it's just more so of the virtual piece of healthcare. Telemedicine, it's not as personal as what we do at NICE with the virtual direct primary care.
Okay.
Oftentimes with telemedicine, it leaves the patients like kind of out in the open, and they're trying to figure out, okay, what do I do for this next step, or where. After this is done, where do I go for this?
There's not a lot of guidance like that's really kind of attaching the next steps to what they should be doing. That's the telemedicine bucket, right? Like call and I've got a tummy ache. My 3-year-old has a tummy ache. Can I get XYZ medicine or something to that effect, right? But you're saying the virtual primary care connects the dots after that to like, okay, what do I do now, right? Or what are the steps of the prognosis to which do we get a successful outcome, right? Is that
right?
Is my understanding correct? Okay.
Yeah. So with the virtual direct primary care, and then even with NICE, we offer the virtual and the in-home component. But the virtual piece is just a component of what we have that leads that patient to some of our other services that we offer.
Okay.
With the virtual visits, we do diagnose about 70%. Within that visit.
Okay.
But then there's also that 30% where the clinicians come out to the home and see that patient.
Assuming it's not an emergency, right? Assuming it's something that falls under their purview. So what's an example of something that might be taken care of in the virtual setting versus needing a clinician out in the home?
Yeah, let's just say you have poison ivy. Take a picture of it. That clinician can see that, it's poison ivy. So that clinician will send a prescription to the nearest pharmacy for you.
Okay.
Whereas, I think I broke my finger, but it's not really broken. Okay, let's send a clinician out to you. We'll have them do an X-ray, and then get back with you and let you know whether or not it's broken, and you need to go to the wherever to get it fixed. So
there's a mobile X-ray unit or something that they bring out with them. So then they'll say, oh, yep, it does look like it's broken. Here's our recommendation. I mean, are you guys tying in the next steps? Is there a relationship or a referral? Like, how do they know where to go after that?
Yeah, so we are very open, and we let the patients know what the next step is, as well as we follow up too.
Okay.
To see how that patient is doing afterwards. But the patient always knows what's going on with that visit. And
so how does a member on the plan actually aware of NICE Healthcare's involvement in the plan? Is this part of an open enrollment education process or a card, an app? Tell me what you guys are doing.
So everything is done through an app, the NICE app. And we have an engagement team that works very closely with each of the groups. With that, I'm sorry. With that, that group receives a utilization report quarterly.
Okay.
So that employer knows that, hey,
what level of engagement's happening?
Yeah, your employees are engaging at this level for these services.
To me, this sounds like an enrichment and enhancement to the benefits, obviously, for the member, but I'm presuming there's also some sort of financial motivation for the employer saving money overall. I mean, is there like a kind of a tangible ROI that you guys are able to talk about as well? I see you smiling, so there certainly must be, right?
Yeah, I mean,
because there's feel-good benefits, and then there's benefits that save money, and then sometimes you get the nice convergence of those two happening, right?
Yeah, it's a win-win situation really for everyone.
Okay.
Employer right now, employers are looking for benefits that are going to help save them on their health spend,
Mhm.
and then also help attract and retain employees as well. And so when they have NICE, employers who implement NICE with their health insurance,
Mhm.
they receive credits back.
Okay.
Mm-hmm.
So credit to their actual premium then? Interesting.
Credit to their premiums, and it's a win-win also for the employees because they're not having to pay anything out of their pocket when
Yeah.
they use NICE.
Oh, so it's a zero out of pocket to them as well.
Right.
Okay.
Right. So the employer pays the full cost of the service,
Mhm.
and it's a flat capitated rate.
Okay.
And that's about $1 a day. So if you look at about $36 a month
Okay.
for the service.
Okay.
And so the employer is paying for that. Employee is not paying anything out of pocket to use the services, and then it's also a win-win for NICE as well.
Well, so is there any situation where, you said obviously it's capitated and there's not an additional cost that's under that bucket if NICE is doing the care? Is there something that eventually might make its way out of the NICE ecosystem because it's just something you guys can't treat and the person needs to go elsewhere for care?
Yeah. So they'll still have access. I mean, they'll still have their health plan.
Of course. Yeah.
And so if it's out of our scope of service, we do get them to their health insurance and say, we can help refer this patient over to that specialist.
Okay, so that's going to then go back in and be absorbed by the plan.
Mm-hmm.
But that makes sense, though, right? Because you guys have this scope of services that falls under your umbrella at a capitated rate. So as long as it falls under that umbrella, then you guys are, obviously providing the service at no additional cost. And then what I see, and I see why probably the carriers are giving you guys credit. It's because some of those things that you treat ultimately would probably be treated in a setting that was inappropriate for that particular condition or virus or whatever it may be, and the cost is probably exorbitant compared to what you guys can deliver the care for. So it all makes sense, right? It's I'm kind of tying a bow on it, but it all makes sense.
Yeah.
I'm intrigued about two things. The virtual primary care is interesting to me. Even direct primary care I find very interesting. Kind of a similar model, but it's a subscription model. Same thing, but that's an in-person, maybe with a phone element, but it's not really so heavily focused on virtual. But I really like the idea. Everything that's old and new again is having somebody come to your house. So that's got to be a little more difficult to set up. Probably why you guys are in, you said 12 markets to date, because then you also have to have doctors that are willing to do house calls, right? So how do you get that up and going?
Yeah, so we actually have nurse practitioners. We don't
Okay.
have any doctors.
Okay,
on
nurse
our
practitioner.
platform.
Okay.
Yeah. We have clinicians in just about every market.
Okay.
And the goal is to, ensure that that our members have access to all of the services and not just one component of it.
Okay. Yeah.
And so everything is done through the app. And if they need that clinician to come out to their home, we can send them out. And
what's kind of the turnaround
enough.
time? I mean, how quickly are most of the time on average able to get out to somebody's home? Probably depends on the time of day, right?
Yeah, depending on the time of day, how busy. But about 90% of the visits can be completed the same day.
They can. Okay.
And that's the actual visits that where the clinicians go out to the patient's home.
That's pretty incredible, right? So
it is. Yeah.
How do you get this thing? And I know you guys probably talk about this all the time. How do we get this to nationwide? What are the challenges to get this thing across the country?
Yeah. So that's underway as well.
Okay.
It is definitely going to come. That is one of the challenges that we hear often about that nationwide coverage. We just want to make sure that you're getting everything, but the entire piece of NICE healthcare, and not just a component of it.
Okay.
That virtual primary care is an entryway into the other services that we have.
Yeah.
So that mental health therapy, physical therapy, the 550 prescription medications at no cost, and labs, x-rays. And so when we go to that market, we just want to make sure that we have adequate coverage for clinicians in that market.
Well, yeah, because like you said, that the entire suite of services or scope of services you don't want to dilute that by only being able to offer one or two, because it
Right.
does dilute the value of the whole package. So then obviously that makes it challenging, right? You got to have clinicians, you got to have the appropriate people for physical therapy. I guess, is the prescription piece challenging, or is that's probably pretty easy to scale?
Now, the prescriptions are actually, you can get it picked up nationwide.
Okay. So then it sounds like it's perhaps just a matter of time, especially I think having that carrier endorsement, for my opinion, is humongous.
It's big.
Having them give you a credit for that, because they're going, like we'll literally give you a credit directly from your premiums for that. I mean, how much more proof do you need in the pudding? So I do want to talk to you, and we'll keep talking about NICE, but I do want to talk to you about sales, because you've been a salesperson for most of your career. What is it like selling this, an innovative solution, as well as this during the time that we've all had over the last year and a half? Tell me kind of the how you've changed your sales approach and what your responsibilities are now.
So I was used to selling directly to that individual or to that group. And now we actually go through brokers that sell our products.
Is that the primary distribution channel? Is the broker? Okay.
Through broker relationships, and building that relationship with a broker is amazing. And just like you mentioned, when you saw that broker yesterday, they talk great about NICE, but that relationship too is important as well. Having that closeness and letting them know that, hey, we are here for you. We're here to help you as well. And brokers are looking for ways to distinguish themselves from other brokers out there.
Of course,
and we know the market is saturated with health insurance brokers.
Yeah.
Everybody's trying to get a piece of the pie, and they're reaching out to all these employers, and employers are just getting overwhelmed with everything that's out there. So, but having NICE, it has really helped a lot of the brokers.
Well, I think, those brokers too, they're looking for what is a solution that makes me stand out. You mentioned how there's just a saturation of so many brokers in the marketplace. It's like, well, okay, how do I make myself, if all my services are relatively similar to some of my competition, I can build a relationship, I can maybe tell a better story, or I can also bring something new to the table that actually that brings value. Oh, wow, this is great. I've never heard of this before. Tell me more, Mr. and Mrs. Broker. So that, once you get, and I've been selling to brokers for numbers of years, once you get them the head wrapped around the concept, how it works, and then get it into the level where they can tell your story simply, right? Because ultimately they become your funnel. Like, I go to the one broker and then they have 100 clients, and now if they successfully tell my story to 100, all of a sudden I have access to potentially 100 new prospects. But the key is obviously getting them to be able to effectively communicate that to them. So what's a kind of timeline of get them educated on your solution? It seems fairly simple in this conversation, but I'm sure it's not that easy in the real world. So tell me how long that life cycle is.
There's really no set limit. There's no set amount of time for the life cycle.
I mean, have you had calls where it's like the first time you have a call and then like, yeah, I get it, I'm going to go sell this right now?
They got it, and they love it, and they want to get it. But then there's times when it takes a little bit longer. Yeah. To close. But
what about the execution of this? So let's say it's in a market you're already set up for. You got a new group. Kind of tell me about the implementation. How does the new employer get wrapped into your ecosystem and things like that?
Yeah, so we make that process really easy. All they would need is just a census, and once they send over that census, and of course sign up for the plan, they are pretty much implemented. Do a phone call, and that's it. Yeah,
and so I'm sure open enrollment, the outreach to the employer, really hammering home the solution is available, because there's value to the employer just as much as the member, and it's a kind of like it's a it's a commingled value because they both derive benefit from it. So messaging is going to be really important. The more the utilization, and I presume the higher the savings, right? Because
yes.
Yeah. So it's like, how do you get them to listen, because these employees are overwhelmed with everything. It's just like, I'm sure you guys keep the message pretty simple to them. Hey, call this number, or what do they do to get engaged? Is it just simply a phone number and an app like you said, or?
Yeah, so that is how they access NICE, but they have engagement specialists that will reach out to let them, update them on everything that's going on. Typically during those open enrollment meetings, I will let them know, hey, follow us on social media. We have a lot of things that get updated on social media. Take some time out and check around, look at all the services that are offered, and schedule like your first exam.
Yeah.
Just to see how it feels. And once they get that first interaction, it's like, wow, this is awesome.
Yeah.
And then they want to keep using it. There's actually times, now that you say that, there's times when they love the service so much that they refer it over to somebody else, and then that referral turns into, okay, I want to get NICE too. I'm going to tell somebody else.
Yeah. Well, members end up being your biggest advocates, right, for referrals. That say, like, somebody uses it and she tells her friend across the hall or it works for somebody else, and then that goes up to HR, and HR goes to the broker, and next thing you know, you got somebody else interested in it. But it's like, that's just, if it works, the people that utilize it are going to be your biggest advocates, obviously. Yeah, and it makes total sense. I do want to ask you, because I don't want to skip over the fact, you mentioned 12 markets. Where are you guys up and running today? So if somebody's listening to this and like, I want to get that, like, well, I want to make sure people understand where they can now and maybe what's coming on the horizon as well.
Yeah, so the quickest way to get a lot of that information, if you go to our website under nice.healthcare.
Okay.
But our main areas right now, we have Minnesota, Wisconsin, Colorado, Utah, Nebraska, Arizona. We just opened in Las Vegas, Nevada, Albuquerque, New Mexico. Oh goodness, I'm trying to think of the map.
Well, that's a lot to remember. Let's get him to nice.healthcare. But obviously, I'm sure some people will be listening like, oh, I'm waiting for my state to be said, because if this benefit does sound tremendous. And then what does it take? Like, what do you think from expansion across the country? Is this going to be a few more years before it's everywhere, or you guys got a target date to have?
That's a really good question, and I'm not sure. I'm really not. I guess whenever it happens, everyone will know.
Yeah, and I'm sure there'll be announcements. So, you're probably like us, where we're just trying to strategically pick the next markets that we go into, because you guys started, I think, similar time frame around 2017, like we did. There's challenges to standing up a business, right? Like, you can have a great product, a great solution, a great story, but then there's operational stuff, there's sales and support staff, and for us, we need lots of developers, so that it's not like you can just flip a switch and your business goes from 0 to 100.
Right.
Unless you've got, hundreds of millions of private equity, maybe they make it a little bit quicker. And so tell me, going from, La Crosse, enormous corporation, to kind of what would be more of a startup feel. Like, tell me what that was. There an initial kind of culture shock of that, or?
Yeah, honestly, it was a huge culture shock, and not because of that. It was more so the people. The people at NICE, everybody was extremely friendly, and it wasn't
are they all really nice?
And it wasn't just a front.
Yeah.
You know how some companies, it's like, oh well, the culture over here is great, we love each other, but no, like it's really different. Like, everybody is so willing to reach out and work with you and help you.
Yeah.
Help you grow, help you wherever you need help, answer any questions. I don't know. It's like, it's a completely different feel. It's so close knit.
That's cool.
And you don't get that from a larger organization.
Yeah, I have a similar experience, right? Like, you have direct line to leadership, right? Like, you're talking, you're strategizing, you have an idea, and it gets put into motion. I mean, there's a lot of that's fun to see that happen in real time. But I think when you have a company that's founded on a mission, like, it seems like you guys are a very mission-driven company, the people that are aligned with that mission that want to work and, attach themselves to that mission are going to be like-minded in that way. So I do believe, you kind of feel like everybody's kind of rowing in the same direction, and it's a lot of fun. And I'm the same way. I've been big corporation, and they do have their advantages of being big corporations. But I found as I've gotten older, I gravitate more towards this style. Because it's also fun because you're telling a story in the marketplace that's unique, and so you get to be involved in light bulb moments where somebody, like, the light bulb goes off and they're like, I get it, like, wow, this is awesome. And you're like, yeah, it really is, and that's why I'm working here, rather than maybe just simply working for a paycheck or something like that. So I did want to ask you, let's make it at least self-funded related for a second. Fully insured versus self-funded. What's the difference in getting Nice up and running there?
Yeah, I mean, it's the same. We can cover both.
Okay.
Yeah, we can cover both. And it's kind of like how I stated earlier, the self-funded plans, they see the value right up front.
Of course.
Because of the claims.
Yeah.
And we had a lot of self-funded groups with Nice.
Okay.
And we also have a lot of fully insured groups as well. But those fully insured groups, where they were seeing the most value was the attraction and retention piece.
I see. So just kind of like a enhancement to the members' experience working for that company, attract them. But like self-funded, does it make it? Do you have to carve it out of the plan document? Do you know that? Okay, so it's not even something that has to be written into the plan or anything like that. That's so
completely separate.
It's completely separate. Well, that's it. That's really interesting, right? If you can make it that simple too for a self-funded employer, because the ROI to me is obvious, right? And I think you can. I'm sure you have statistics where you can draw the dollar for dollar savings or whatever it may be, and then it's like, well, why would you not? I always feel like I need to ask this question because I don't want to get too sucked into some new idea, and it's like, wait a second, what am I missing? Is there any group that this isn't outside of, like, hey, we don't cover that geographic area? Is there any situation where that may not be a fit? Is there a type of employer that it's not a good fit?
Not really.
Okay.
No, I mean, employers use it no matter what type of insurance, even if they don't have insurance for certain employees, like the part-time employees. They can still use
this.
They can still get Nice. And what's great about it too is that with Nice, it doesn't just cover the employees; it covers their household members as well.
It does. Okay.
Yeah.
So all their dependents in the household, and so. There's got to be a downside. I want a downside, But obviously, I think the most obvious one, at least listening to you, is, of course, if you can't offer all the services in that location, it does dilute the value. But I can see why. I don't want to out the firm, but I can see why they've attached themselves so quickly to this, and they love it. It makes a lot of sense to me. And this is what gets me excited, is having conversations like this and getting to learn about new solutions, and whatever I can do to raise awareness of Nice. I'm sure you guys are doing a great job, and Director of Growth, I know you do a lot of that yourself. So what do you think, kind of more broadly, if we take a step up, not just Nice, but more broadly in the healthcare space? Like, you're doing your dissertation about community outreach at clinics. You obviously got the Nice thing. What do you think about healthcare at large? Like, where are we going with this?
Yeah, I think we're going to see a lot more of this. The market is just very consumer driven. And consumers want more affordable healthcare. They want more affordable healthcare. They want more care that's convenient as well. And I think it is going to start to go back to how it was before, where you have doctors and clinicians coming out to the patient's home rather than that patient having to go to a facility. When you think about it, a lot of clinics are moving away from the brick and mortar. The brick and mortar model, and then also the fee for service is broken too. The fee for service care, and so they're moving more toward that capitated rate, the set rate for the services. So I mean, overall, I see more direct primary care just in general moving toward the type of model that Nice has.
Yeah. Well, I think it's funny. I mentioned earlier what's old, it's new again. I remember the movie Field of Dreams when I was a kid, and it's a movie about kind of baseball, kind of tangentially about baseball. But I remember there's, the doctor would do house calls, and I was like, I was fascinated by, hey, you can get a doctor to, bring his little doctor bag and go check on your child in your house. And I know that was the norm, I don't know however many years ago, 100 years ago, or even less. But like, why did we stray away from that? It just seems like every time I go to the doctor nowadays, outside of if you were in a setting that was like a direct primary care model, you always feel like you're being rushed in and out the door, right? You wait for half an hour, and then you see them for 5 minutes, and they're scribbling their notes, and you feel like you don't even have time to really flesh out your problem or what you need to talk about. And it's like, oh, they're on to the next one. So I presume, obviously, there's a longer duration of time that there's being spent with the patient in this model too. Yeah,
it is. And our clinicians, they do spend a lot more time with the patients, and the reason that is because we want to make sure that we address all the health issues, and not just the one thing that you are telling us about, because there's some underlying health issues that could also be corrected at that time as well.
So, I do think you probably are onto something, that the more localized care. What's the gentleman, Dave Chase, has the Healthcare Rosetta? I forgot what his book is called, but he talks about relocalizing healthcare. It's like taking it back away from like this big private equity model and hospital systems, and like delivering it at the point of the actual individual member where they need it. And like, I can't think of a more individualized way of doing so than having somebody actually come into your house, which is really, really cool.
Right.
So, well, last but not least, how do we get a hold of you? We mentioned nice.healthcare. How do people find you if they want to ask you more questions about Nice?
Yeah. You can find me on social media. So LinkedIn, Chetara Brisbon. You can ask me any questions, personal or about work, whichever. So be happy to connect.
And yeah, Chetara, and it's been an absolute pleasure. And again, thank you for coming in. Any closing remarks, anything that you want people to be thinking about as we go on our way?
Yeah, thank you as well for having me here. Other than everything that you went over, I mean, I think that covered just about everything. Yeah.
Well, Nice Healthcare, and by the way, nice name. Right? Nice healthcare, nice and simple. And you mentioned everybody there is nice. Everything about Nice sounds nice, not to be too cliche. So I do appreciate it. Thank you for coming on and helping kind of long form flesh out the solution for me and for hopefully the people that are tuning in. And I wish you guys the best. I wish you personally the best with your dissertation as well. So please keep me posted on the outcome of that. So thanks again. And maybe we'll have you back here sometime soon as well.
All right. Thank you.
Take care.
You as well.
Bye.